Hello, welcome to today's What's New in Research webinar. I'm Jenna Invalo, and I'm the National Director of Programs at the MGFA. We've got a great session for you today. Before we get started, I want to go over just a couple of housekeeping items. Today's session will be recorded and available on the MGFA website after it's been posted. If you would like to use closed captions during the live presentation, please click on the CC box located at the bottom of the Zoom menu bar and select your language of English. We ask that you submit your questions in the Q&A box located at the bottom of the Zoom menu bar, and they'll be answered during the Q&A section. We've got a great presentation today, and we'd like to thank our sponsor, Kyverna. And now it's my pleasure to introduce today's speakers, Professor Sri Mupidi and Dr. Naji Jaikhan. Welcome.
Thank you so much, Jenna. It's great to be here, and thank you for allowing us to share our presentation. So let me start sharing here. Really great to be here today with all of you to share a new approach to generalized myasthenia gravis, the CAR T-cell therapy. I have the pleasure to be joined by Professor Sri Mupidi, who's a clinical professor of adult neurology at Stanford, and I'm Naji Jaikhan, the Chief Medical Officer at Kyverna. We will be sharing today about an investigational drug. So CAR T-cell therapy, even though they have been approved since 8 years now in oncology, is not yet approved for the treatment of autoimmune diseases. This therapy is only available to people with certain autoimmune diseases and ongoing clinical trials evaluating the safety and effectiveness. KYV-101, it's Kyverna's CAR T-cell therapy, is an investigational therapy that has not yet been approved for use by the FDA. And all the discussion and use of KYV-101 is limited to the context of clinical research and scientific exchange of information. So it's not intended as medical advice, no suggestion that KYV-101 has been found by FDA to be safe or effective or authorized outside of use of clinical trials. So today we will be talking about this new approach to generalized myasthenia gravis with the CAR T-cell therapy. So Professor Mupidi will be taking us through that. Then I will be sharing more about who we are as Kyverna, a company that is focused on autoimmune CAR T-cell therapy. And then we'll take you through our clinical research, specifically in generalized myasthenia gravis. And we will have the opportunity for a Q&A where you will be able to ask your questions and we will be answering those. So with this, I'll hand it over to Professor Mupidi to take us through the myasthenia gravis treatment landscape.
Thank you so much, Naji. Good morning, good afternoon, good evening. If you're in Australia, it might be very early morning. Thank you for joining us today. We'll briefly talk about MG treatment landscape and where CAR T falls into the picture. And just from my own experience, many of the patients who join these sessions are quite well versed with the language, but we wanted to make sure that we're all on the same page. So I'll try my best to explain some of the wording and what they mean and how is CAR T different from all the therapies that have been approved for myasthenia in the last few years, at least in US and internationally. Next slide, please. So myasthenia is a complex and a challenging disease. We like to say that no two patients are the same. Everybody has different patient needs. For example, if a patient has significant weakness in their arms or legs, difficulty swallowing, they have difficulty with double vision or eyelid drooping, with a lot of the therapies that we are able to offer, we might be able to get them much better. But sometimes certain symptoms like the eyelid drooping and double vision might be persistent. We usually talk to patients, try to understand what their goals are, and we discuss, do they want more therapies for the residual symptoms? Are the therapies acceptable for them? In contrast to that, if somebody only has double vision, let's say I've had a surgeon who has double vision, well, that's not acceptable. None of us would want to go to a surgeon who's seeing two of you, right? And so we would treat them differently. We always choose therapies based on how a patient is doing and what's valuable for them. There have been many therapies that have been approved in myasthenia over the years. In spite of all of these therapies that have been approved, and myasthenia has been quite blessed with the number of therapeutics that have been developed for the field, there are many patients who do not have perfect symptom control. Our symptom control is not optimal for them. Just going back to that surgeon who had double vision, he had to have perfect vision, otherwise it's not good enough. And even though we have all of these therapies available, many patients do not meet them minimal symptom expression criteria. For those of you who are not aware of this phrase before, minimal symptom expression means that MG-ADL or myasthenia gravis activities of daily living score of either 0 or 1. MG-ADL is a commonly used patient-reported outcome measure as to how patients are doing in terms of their activities of living as affected by myasthenia. Other important thing about current therapies, while they're effective, is that you need to be on those therapies going forward to experience the benefit. So for example, FcRn therapies or complement therapies, they are effective while you're on them. Very rarely are you able to completely come off those therapies and then still have persistence of effect. And so naturally, this means that patients require chronic treatments. Other oral medications that we usually use as oral immunosuppressive drugs certainly need to be on board for a long period of time. And so we certainly need therapies that have a durable effect, as in have an effect after treatment for a long period of time. Improve the whole of the patient, not one symptom or the other. And this is where CAR-T really comes into picture. It's a novel therapy, and we'll talk a little bit about it. Because it's a one-time treatment, it has real potential to change how we think about treatment myasthenia, change the paradigm that we currently use in terms of thinking about what is the next drug to use and what is the risk benefit. Because it's novel, certainly we need some time to figure out safety side of things. We also need some data regarding how long is the benefit going to last for. I generally use 1 year as a sort of a rough marker to assess both safety and then benefit. Obviously, longer is better. Next slide, please. How does CAR-T therapy help with patients with myasthenia? Most of you might have seen the little cartoon on the right side with the nerve and the muscle, and the top is the nerve structure, and the little undulator structure is the muscle. And so the acetylcholine is released from the nerve, attaches to the muscle, causes muscle contraction. The little Y-shaped structures that you see are the antibodies. These antibodies either bind to the muscle or cause complement activation when they bind to the muscle, and then cause problems with weakness and failure of the transmission from the nerve to the muscle. Where do those antibodies come from? These antibodies are produced by B cells, one of the immune cells, which play a critical role in a whole gamut of autoimmune diseases, especially in myasthenia. They are stimulated by mistake to produce these antibodies to attack the muscle membrane receptor. In myasthenia, these antibodies are produced by B cells, and the antibodies bind to the muscle membrane and cause weakness. CAR-T therapies, especially Kyverna CAR-T therapy, is specifically designed to attack these B cells and remove these B cells. So once you remove them, attack them and remove them in the system, especially the unhealthy ones which are producing the antibodies, they're not able to produce the antibodies. And so you're able to reduce the disease activity dramatically because you are targeting the cells that are producing the antibodies, and patients should experience in the same way a significant improvement in symptoms. Next slide, please. What does CAR-T stand for? CAR stands for chimeric antigen receptor. And so essentially what it means that we take patients' own T cells. If you look at the little cartoon at the bottom, T cells are another type of immune cells. We take patients' own T cells, and then outside in the lab, a viral vector is introduced into the T cell, and that expresses further receptors, those little wrenches, the red wrenches that you see. And those receptors, after they're expressed, they are able to identify the B cells. Now, if you read about CAR, there are many different types of CAR-T therapies, and they're all based on, the naming is based on what is the primary target of the CAR-T cell therapy, what are the different features of the CAR-T therapy, and then you'll see a little enlarged drawdown box which says CAR. There are features based on what's expressed outside the cell, what's expressed inside the cell. This tells us how well does the CAR work, how quickly does it expand, how safe it could be. And so there are different features to different CAR therapies. And you might have heard about different companies studying this. But in general, the principles are the same. We take patients' T cells, and then the viral vector is introduced that produces the CAR, and then we give it back to the patient. And so if you go to the next slide, please. And then, so this is how it would work. We take the patient's T cells in a lab, and there are lots of quality control metrics that go into producing these things. We produce the CAR T cell that is derived from the patient's own T cells. Generally, about 100 million cells are produced, for example, and then the patient is given those CAR T cells. Now, these CAR T cells now are programmed with those little red wrenches that you're able to see. They're programmed to go and attack the B cells, patient's own B cells, across the spectrum, all B cells, including the B cells that produce the antibody. And so once you attack those B cells, all of those B cells will be taken away from your body system, especially the ones that are producing the antibodies. And over a period of time, normal healthy B cells, the kind of B cells that are not producing the antibodies, should be able to come back up. And so essentially, patient should be able to get some of their immune system back up and running, but without those cells that are producing the antibodies. And that would be the ideal case scenario where their immune system resets so that they're not producing those antibodies that can cause the disease. Next slide, please. And so what about CAR T? Is it new? Well, it's new in the autoimmune space. There have been more than 250 clinical trials in cancer. A lot of these are blood cancers, multiple myeloma, lymphoma, so on and so forth. And there are multiple therapies. There are about 7 of them of different types of CAR Ts that are already approved for different types of cancers. But because they can attack the B cells so well, and they can attack all the B cells throughout the body, not just the B cells in your bloodstream, they become a great opportunity to treat patients with autoimmune disease. You might have heard about news publications in New York Times and other websites about the promise of these drugs. So currently there are about 45 different clinical trials across the board in different autoimmune diseases. Myasthenia, even though it's relatively rare compared to other autoimmune diseases, it has become a natural target and an opportunity to test these treatments and offer it to our patients in clinical trial programs, because myasthenia is a B cell mediated antibody producing process. So the B cells in myasthenic patients produce the antibodies. And so if you have a CAR that targets the B cells, there's a potential for dramatic improvement. With all the therapies that have happened in myasthenia over the years, we know that if there is a targeted therapy, that can really make a big difference to a patient with myasthenia. So we're very fortunate in that sense that myasthenia is one of the diseases where these therapies have been studied. Overall, more than 45,000 patients have been treated with CAR T therapies throughout the world for different diseases. And then, as I mentioned, many different patients and patient groups are being treated for the autoimmune diseases beyond the cancer patients. Next slide, please. What to expect when you are trying to sign up for a CAR T therapy? As Naji mentioned earlier, these therapies are not FDA approved currently for any of the autoimmune diseases. But the process of treatment, even in a clinical trial, is slightly different from if any of you participated in a clinical trial before, slightly different from that kind of process. There are multiple steps to CAR T process. It does require much more closer collaboration with your treating physician. Before we treat the patient, we actually take the T cells, so the blood from the patient. And from there, the T cells are extracted, as I mentioned earlier, shipped off to a lab where the CAR T cells are produced. And then before they're given back to the patient, a patient has a low-dose conditioning therapy, a very small dose of chemotherapy kind of therapy, so that the patient can actually receive the T cells and then tolerate receiving the T cells. Then patient is admitted to the hospital, and on the infusion day, it's a single bag of the CAR T cells that are given. And then post-infusion, we monitor the patient usually from 7 to 10 days for different kinds of complications or side effects. Fortunately, so far from all the published literature, the complications and side effects in autoimmune diseases seems to be much less than what's published for patients with cancer. After the hospitalization, patients are discharged. Most of the time when they are discharged in these programs, they're off all their prior immunotherapy. And so that's really quite of a relief for patients not to have to worry about taking other immune therapies. But patients are followed in the clinical trial on a very regular basis for the first few weeks on a much more frequent basis, and then less frequently going forward. There are additional criteria regarding being available to come to the hospital. So we ask patients to live close by to the hospital so that they can always come in if there is any questions or any concerns, and we have access to them and they have access to us right away. So it's a slightly different process compared to other clinical trials and other therapies. It involves taking patients' own T cells first, preparing the cells, and then conditioning them so that they can receive the T cells, and then sort of a very close and detailed monitoring over a period of a few weeks to a few months. We always follow all patients for many, many years, but initially we follow them on a very close basis, almost weekly, and then less frequently with time. Next slide, please. You might be thinking, well, I've heard of all these new therapies that are already approved for myasthenia. There are TV ads. How is this therapy different? So we'll start from the bottom of this figure, for example. So the acetylcholinesterase inhibitor, that is mestinon or pyridostigmine, most commonly used agent, it increases the amount of acetylcholine at that nerve muscle junction and improves the strength a little bit. There are newer therapies that have been approved, for example, FcRn therapies, that reduces the antibody levels but doesn't do anything to the production of the antibodies. What about complement inhibitors? There are many complement inhibitors that are FDA approved in US for myasthenia, AChR positive myasthenia. And so they prevent complement deposition on the muscle membrane, the undulator surface that you see at the bottom. But there are also B-cell therapies which are called monoclonal antibodies. For example, rituximab is one that's sometimes used for MuSK myasthenia. And so these B-cell therapies, these monoclonal antibodies, they attack B cells, but they only attack B cells that are in the bloodstream or in the circulation. They're not able to attack B cells that are in lymph node or other structures and still produce the antibodies, but the monoclonal antibodies are not able to target. CAR T therapy is unique because it's able to target B cells throughout the body. That's in the cells that are in the bloodstream, the blood cells that are in bone marrow, the cells that are in the lymph node. So you have a significant reduction in the B cells, and especially the B cells that are producing the antibodies. And so as you will see with some of the data that's being presented today, and you might have read about it online, some of the levels of improvement that we notice in patients is quite dramatic. And this is reflected by the fact that we have such a dramatic improvement in overall reduction in the antibody level and how we're able to target the B cells. That's very specific. And then I'm going to let Naji talk a little bit about how the Kyverna team comes into picture and the KYV-101. Thank you.
Thank you so much, Professor Mupedi, for this great overview. So as shared, I will be introducing you to Kyverna, our company, and specifically KYV-101, Kyverna's CAR T cell therapy. Before I start, we wanted to share with you the first myasthenia gravis patient who have received KYV-101. So this patient have received KYV-101 under a form of compassionate use in Germany called IH, as you will see in this video. This patient is now 2 years out without symptoms and background immunosuppressants, as Professor Mupedi shared. So this story you will hear here from Denise is certainly one of those stories. It does not warranty, as our asset is still in clinical research, and we will need to confirm in clinical trials. It does not guarantee the same the same effect in every single patient. I'll let you watch her video.
Die ersten Symptome hatte ich beim Laufen, haben zunehmend die Beine nachgelassen, dass sie einfach so eingesackt sind. Und dann fing es an, dass es auf gerader Strecke auch so war. Die Ärzte haben ja immer zu mir gesagt, ich bilde mir das ein, da wäre nichts. Und ich denke mir, ich bilde mir das doch nicht ein, ich fall doch hin. Hieß es irgendwann, ja, ich verliere zwischenzeitlich das Bewusstsein. Und das war auch nicht der Fall. Ich konnte denen ja genau beschreiben, was passiert. Ich musste gepflegt werden, gewaschen, gefüttert und so weiter. Ich habe dann immer mehr Probleme beim Sprechen und Schlucken gekriegt, sodass ich dann nur noch flüssig nahm. Mein Job ist, mich um meine Kinder zu kümmern. Konnte ich nicht aufgrund meiner Krankheit, weil es teilweise so schlimm war, dass ich mich selbst nicht verpflegen konnte. Und dann nach 2 Jahren hatten wir dann die Diagnose durch einen Bluttest. Wir haben ja hier ganz viele Therapien versucht. Wir haben ja die Thymusdrüse entfernt, dann haben wir verschiedene Therapien probiert und so weiter. Und alles hat immer nur so zeitweise funktioniert und danach kam wieder der Einbruch.
In Germany, we have a law, the so-called individuelle Heilversuche. This allows the physician to apply therapeutic approaches that are not approved in those patients where the regular and approved drugs have been exhausted or there is nothing available. I was intrigued by the option to apply CAR T-cell therapy. Denise is one of these cases. We have been trying to stabilize her disease for the past 3 years. She needed ICU care several times with ventilation and intubation despite an efficient immunotherapy.
Dann hat der Chefarzt von der Therapie, dieser Zelltherapie gehört. Da habe ich gesagt, klar habe ich Interesse dran. Ich möchte alles, was mich voranbringt, was mir hilft, dass ich dann auch wieder für meine Kinder da sein kann und so weiter. Und als es dann soweit war, dass die Infusion dann kam und da war ich die Ruhe selbst. Aber bis dahin war ich total nervös. Aber dann in dem Moment war alles gut. Ich wusste, ich kriege das jetzt die Infusion und gut, kein Problem mehr. Und ja, je mehr Tage vergingen, je besser ging es mir. Und dann war ich oben, war total begeistert und denke mir, wow, ich bin die Treppe hochgelaufen, wie das denn? Konnte ich ewig nicht und hat funktioniert. Und jetzt bin ich hier den Fahrstuhl nutze und mich sieht jemand dann immer so, nein, 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 wir können aber die Treppe nutzen.
This is really what motivates us here at Kyverna. So Kyverna, we're a cell therapy company with really this mission to liberate autoimmune patients through the curative potential of CAR T-cell therapy. The story of Denise and stories of several of patients with autoimmune diseases is really why we're here, why I wake up every morning, why our team comes to work every day to be able to hopefully bring through our clinical trials and later on through approvals, those CAR T-cell therapy to patients. So what have we done so far? This is really our CAR T-cell therapy research that we've done at Kyverna. So the first the first 2 diseases we've been studying are neuroimmunological diseases. You can see the first one is stiff person syndrome. So this is also a neuroimmunological diseases that is debilitating, unfortunately, for patients, and it's a progressive disease that they would have. There is no current approved FDA therapies for this disease, and we're really here at the last stages of our clinical research, late phase clinical research, with our pivotal trial reading out and hopefully submitting if the data is positive to the FDA in the first half of 2026. Also, what I will be sharing and the focus of today's webinar is myasthenia gravis. So I'll be sharing more with you today the data from our phase 2 trial. So this is an interim data that we've had for our phase 2, and we are open now with our phase 3 trial, enrolling on this trial for myasthenia gravis. But we also have different indications that have been more in the early clinical trial space, lupus nephritis, multiple sclerosis, rheumatoid arthritis, and several other indications that have been dosed with KYV-101. So up to now, we have more than 100 patients who have been treated with KYV-101 across all those multiple autoimmune diseases. And this provides, obviously, an important data set for us to understand better the safety, but also allows us to move in late phase development of our construct. So what is KYV-101? As Professor Mupedi shared, it's a CAR T. So you see here the same visualization that Professor Mupedi shared. And this is KYV-101 CAR, which is still an investigational therapy. But this novel approach allows us to have one administration that is made from the person's own immune cells, specifically T cells, as Professor Mupedi shared, to fight the disease. So KYV-101, once it's manufactured and given back to patients, it has this ability to eliminate B cells, including the unhealthy B cells that are producing those antibodies in autoimmune diseases, those autoantibodies that generally contribute to the disease activity, like in myasthenia gravis. So let's focus now on our research and what we have so far in myasthenia gravis with Kyverna. So currently, our investigational research program in myasthenia gravis is KYSA-6 study. So we have an ongoing phase 2 with 6 patients who have been enrolled. And this is part of I will be sharing today the data from this phase 2. We call it an interim analysis. So we have a certain follow-up of these patients, and I will be sharing the first results from this trial. And as I shared, we have aligned with the regulators and the agency, and we will be moving forward on opening our phase 3 trial, which is now we have a few sites already open to enroll 60 patients in this phase 3 trial with the objective to show the efficacy and safety of KYV-101 in myasthenia gravis, and I will be sharing more details with you on that. But before we go into the data itself and what we've seen in the phase 2 trial of KYSA-6, it's important, and Professor Mupedi touched on this, how do we know that a drug works in MG? So we look at these scores. So MG-ADL is one score that most of you might be you know it pretty well. So this is really looking at the daily living scale activities and the impact on your daily life. So it goes from brushing your teeth, combing, breathing, swallowing, etc. And you would score from normal is 0 and 24 is the most severe. QMG is another score that we use in clinical trials mainly. So probably those of you who have not been in clinical trial, your treating physician would not be using it in normal practice. But this is a very important scale where it quantifies the disease severity based on impairments in the body functions and structures. So physicians will be using this scale in physical exams, and they would score ranges on the scale between 0, which is normal, to 39, which is the most severe cases. Minimal symptom expression is something also Professor Mupedi shared before. This is really looking at the remission, like patients who would have no symptoms or really very low symptoms. So it's defined by MG-ADL score of 0 or 1. So more recently, with the advances, this is something that has been used now to measure the success of myasthenia gravis treatments. What we also obviously are looking at in research and all the time in the industry is how we monitor safety. So specifically for CAR Ts, as it was shared before, we look at something called cytokine release syndrome and immune effector cell-associated neurotoxicity syndrome, so CRS and ICANS. So those side effects have been seen in oncology before and in autoimmune diseases. They may be potentially serious, life-threatening, but generally they resolve within the first month after treatment. You can see here the symptoms for CRS that can be fever and go into low blood pressure, and ICANS from fatigue, and also it can have, it's really neurotoxicities or other neurological symptoms. What is really key to understand, as Professor Mupedi also shared here, what we've been seeing in autoimmune is not the severity that we've seen in the beginning in oncology. But most importantly, people receiving those treatments are always in care of a doctor who is monitoring closely those side effects. And now we've gone a long way in autoimmune diseases to treat those symptoms very early on so that we help prevent their worsening. And as I shared, what we've seen so far with KYV-101 with more than 100 patient dose, we have no high-grade CRS and no high-grade ICANS. So our safety profile is very consistent and it's manageable as we've been seeing so far. So now if we look at the phase 2 interim analysis that we have. So what you're seeing here on the slide is the MG-ADL score for the patients who were in our phase 2 trial, so the 6 patients treated in the clinical trial participants. What's really here very encouraging in the data that we're seeing is this profound impact on MG-ADL score, dropping as early as the first 2 weeks. And this is sustained over the course of the follow-ups that we've seen for those patients reaching 24 weeks and 36 weeks, where we see that this robust drop in MG-ADL is maintained over those follow-ups. What is also important, as our data read out, we see a clinically meaningful response, which is based on the scores that I shared with you before, in 100% of patients, meaning all 6 patients have had clinically meaningful response, well beyond what is clinically meaningful when we look at this profound drop in MG-ADL and QMG. And most patients are at or trending towards minimum symptom expression. As Professor Mupedi also shared, one key promise of CAR T-cell therapy, and in our clinical trials, it's done by design, patients will be off immunosuppressants, so off high-dose steroids and non-steroidal immunosuppressants and any other treatments. And 100% of the patients in this phase 2 trial were off background immunosuppressants up to 24 weeks, and 5 out of the 6 patients remained off immunosuppressants in their last follow-up. When we look at the safety, as I shared, we have here a consistent and well-tolerated and manageable safety profile. So we have only low-grade, mild to moderate CRS. 4 of those CRSs were fever as the only symptom. There was no ICANS, so no neurotoxicity syndromes have been observed in those patients. 3 out of the 6 patients experienced severe low blood counts. This is something expected with the CAR Ts, but also as Professor Mupedi shared, with the lymphodepletion regimen. This is expected side effects that we've seen, and they were all manageable with standard medications, and patients improved at their last follow-up. So we are now enrolling our phase 3 part of the trial of KYSA-6 for people living with myasthenia gravis. So this is a global trial that is open label, randomized study of KYV-101 versus standard of care immunotherapy. And where we are looking as a primary objective of this phase 3 trial to establish the efficacy and safety of KYV-101 versus standard of care. You may be able to participate in this phase 3 portion of the trial if you are between 18 and 75 years old, if you have been diagnosed with generalized myasthenia gravis, according to some specific criteria of this disease, if you have tried previous treatments, but your disease is still not well controlled, and one of the criteria is also having positive autoantibodies known in this disease as anti-AChR or MuSK. So what can you expect as a patient enrolling in this trial? So the first step is obviously screening, making sure that you are eligible to be enrolled in the trial. Then comes the part of apheresis and CAR T-cell preparations, as Professor Mupedi shared. This is the first part that you will be having, and you will go on your standard of care back on your standard of care during this period. Then once the T cells are ready, the CAR T cells are ready, you will go back and you will be randomized. So what we call 1-to-1, so it's basically 50% of patients will be immediately on KYV-101, 50% will continue their standard of care, knowing that after 24 weeks, you will be able to have KYV-101 in the crossover part. So all patients will be receiving KYV-101. Some will receive it immediately after randomization, and some will be receiving it after 24 weeks on standard of care. All patients will be followed up to 18 months in the trial. So if you're interested to learn more about KYSA-6 and taking part in the trial, there is this website, and we will make sure we will get back to it, myastheniagravistrials.gov. But also there's this QR code where you can take your camera and flash it, so it takes you to this website, and the email clinicaltrials.info@kyvernatx.com if you have any questions on the trial. But certainly, most importantly, make sure that you discuss this with your treating physician, with your doctor, who can refer you to a trial site, or you may reach out on the website or through this email. If you are selected for screening, the trial doctor will assess you to confirm your eligibility for trial participation. This may include performing additional tests and for you to be able to enter this randomized trial. These are the current sites open in the US. So we have University of California, Stanford University, University of Miami in Florida, and Intermountain Medical Center in Utah. But we are continuously with the teams working to expand our sites in the US and globally to make sure that we are covering the different geographies in the United States. So please stay on the lookout through our website, but don't hesitate to reach out to clinicaltrials.info@kyvernatx.com, where we can where the team can provide more information. So today's summary, before we go into the Q&A session, what we covered today is myasthenia gravis as a complex autoimmune disorder where people need more treatment options. CAR T-cell therapy is a personalized medicine that is made by collecting your own T cells, adding CARs to those T cells, and then returning them to the person through a one-time administration. And by doing this, those CAR T-cell therapy targets the B cells, and including those unhealthy B cells producing your autoantibodies, and has the potential to address generalized myasthenia gravis. Kyverna as a company we're currently enrolling participants in the phase 3 registrational trial with our investigational CAR T-cell therapy called KYV-101. You can certainly learn more at myastheniagravistrials.gov. So with this, I will move us to the Q&A part of the discussion, and I will be joined by Professor Mupedi for this part. So let me go on for the Q&As. So Professor Mupedi, I'll start with the first one. How selective is the B cell targeting? How would this be different from rituximab? So that's a great question. I'll let you answer it.
That's an excellent question. I was telling the MGFA team a couple of days ago, I'm always impressed by some of these questions because I was reading through the questions, Naji, while you're presenting. They could easily be in any of the scientific meetings and would be completely appropriate level. And so for the rest of the audience, just so that we're all on the same page, we talked earlier about how B cells are the cells that are producing the antibodies. B cells have a different process from the birth to until the end of the B cell life cycle. And so we sort of got a B cell spectrum there. And they all express different surface antigen on top of it. That's how we identify different type of B cells. And so the rituximab, one of the monoclonal antibodies that target B cells, are targeting CD20, which is the receptor on top of the B cell, and that involves a certain group of B cells. The Kyverna KYY-101 targets CD19, so much more broader B cell expression that is being suppressed. And so in that sense, it's a much more broader. The second one that I mentioned earlier in the presentation, monoclonal antibodies like rituximab essentially only target the B cells that are in the bloodstream. They don't target the B cells that are in the tissues. And this is not a hypothetical assumption. This is based on data that's been published in patients with autoimmune diseases who've had CAR T therapies. They were able to take a lymph node sample before they had CAR T and after they had CAR T, and they were able to show that the B cells in the lymph nodes are also suppressed. We don't necessarily see that level of response when we give monoclonal therapy. So the key take-home message in general is that the CAR T therapies, which targeting B cells, have a much greater level of B cell suppression, naturally have a greater level of clinical improvement compared to monoclonal therapies, such as rituximab. Not that monoclonal therapies don't have a place in treatment, they're effective in many ways, but the level of B cell suppression is much, much higher.
Yeah, we usually, exactly how you shared, Professor Muppedi, talk about this breadth of B cell depletion and the depth, as you said, that has been seen in the tissue with CAR T cell therapy and KYV-101. The second question is, what are the known side effects for CAR T? I'll let you start and I can also jump on
Sure.
KYV-101.
This was already covered. The two main side effects that we watch for the CRS and ICANS, CRS presents with fever and other symptoms. ICANS is sort of a neurological syndrome. And so we actively watch for this. That's one of the reasons patients are in the hospital after CAR T therapy. And earlier I was alluding to when you suppress the immune system significantly, we always obviously make sure that they're able to fight infections. We watch for those things, both acutely, as in right after the treatment, and then longitudinally over a period of time. One thing that's important to emphasize is that a lot of the side effect profiles that have been described, like the CRS and the ICANS, these are described in patients with cancers. And those complications or side effects are much more severe in patients who've had cancers that are getting these treatments. When we look at all the published literature for autoimmune diseases like lupus or muscle disease, the degree of the side effects that have been published to date is much lower than what we see in cancer patients. It's not zero. We certainly don't take it lightly. And in clinical trial, all clinical trials have very strict criteria on how to manage them, how to recognize them. We do take them seriously, but the risk is a lot lower than what you might have heard about or seen from the cancer literature.
Yeah, thanks for that. I'll just add, as you shared, for KYV-101, what I shared here in the phase 2 part. So certainly we looked at CRS and ICANS. There was no neurotoxicity in the 6 patients, and CRS were all low grades. So yeah, it's consistent also with what you've shared, Professor Muppedi. Another question that is also, again, great is on seronegative patients. And would this therapy be used for seronegative patients, but also would it be used for ocular-only MG with ptosis and double vision along with daily fatigue?
Great question. And these two, as so many of these therapies are currently approved for seropositive patients, many of my patients who don't have detectable antibody, I try to emphasize that it's not that we don't want to treat seronegative patients. That patient group certainly requires a lot of newer therapies. In the clinical trial, currently, it's for patients with generalized disease who are antibody positive. Part of the challenges when we do clinical trials is to try to find patients who have active disease so that you're able to see a clear response. And I suspect in future it might expand to other disease groups such as seronegative. Just to make sure, again, the whole audience is on the same page, we actually believe that even though it's seronegative, they have an antibody that we don't know quite the way of detecting it currently. It's not that they don't have an antibody. So in future, some of these therapies might be available for seronegative patients, but currently in this clinical trial, it's seropositive patients and generalized MG. By no means to suggest that other disease groups are not symptomatic, are not disabled, or bothered by it, but clinical trials require a certain degree of homogeneity of the patients, a similar degree of symptom burden, so that we can actually evaluate if the treatment made a difference or not.
Great, thank you. And on the part on ocular-only MG with doses, so the trial is for generalized MG with MG-ADL scores of more than 6 or QMG of 11. I don't know if you want to add something else.
Yeah, so so if you only have, and if you have done an MG-ADL, if you have only eyelid drooping or double vision or combination of them, you will only score 6, but there are no other additional features. So we do require, because the therapy is innovative and there is a lot of commitment involved, that patients have active symptoms, so we can actually tell that we made a big difference for them. And so patients do require eye symptoms that are very clear and obvious. Yeah.
So another great question is, for the 6 patients in the phase 2 trial, what was the age range for these patients? And do any of them had comorbidities? So we had a mean age of 45.5 years, and the range was anywhere between 21 to 62. So as we shared in the phase 3 trial, age is between 18 and 75 years old. There are some specific autoimmune comorbidities that are exclusion criteria in the trial. So this is to answer that question. Another question is, if in remission, while on mycophenolate and prednisone, will this treatment be available to us?
Good question. Currently, no, not in this clinical trial. I'm not aware of any other clinical trial that is testing in remission. And just to make sure we're all on the same page, remission to us means that there are no active symptoms, even though they might be on treatment. While it is true that one-time CAR T therapy allows you to come off some of the background therapies, as I mentioned earlier, in a clinical trial program, we like to identify patients with symptom burden or symptoms that are measurable and objective so that we can actually show an improvement. And so currently, if you are doing well, wonderful. You're obviously happy that you're doing well. And then it's something to talk to your doctor about. Do you need all the therapies that you're on? But this program might not be the right place at present.
Another one is on the standard of care group. So I can start, Professor Mubedi, and I'm happy to complement. The question is on the phase 3 KYSA-6 trial. When we say standard of care group arm, does that mean you won't get any treatment or continue with your normal treatment?
Yeah, a very good question. Actually, Naji, do you mind going back to that slide if you're able to?
Yes.
Just so that we can emphasize it, and it's important question. And so patients come in on treatment already to begin with, and so during the apheresis part, they're weaned off some of the treatment so that we're able to extract enough T cells, and then they go back to what they were on before. And so they can certainly go back to the treatment that they're on, which is standard of care. It's a phrasing used to say that whatever the treating physician and the patient feel like it's the right therapy for them, usually FDA-approved therapies. There are certain requirements regarding certain therapies, whether they could be continued during the standard of care or not, and we can certainly, your treating physician will discuss with you, or your research physician will discuss with you. But in general, you can go back to the therapies that you're on. You are never off all your therapies for a prolonged period of time. We don't take patients off therapy and then wait them, sort of watch them struggle. That's not the goal of the treatment, the clinical trial at all. So you're always on therapies. We always make sure that your symptoms are as well controlled as possible.
So another one, Professor Mupedi, is I think about the apheresis. So the question is, does this involve a blood transfusion of patient's own blood, or is it a fraction of the whole blood that is reinfused. So maybe if you can explain a little bit more the process of apheresis and what actually is done.
Great. So apheresis involves, there is no actual transfusion that's being given during apheresis. We only extract your own T cells, your own produced T cells, and nothing is actually being given to you. You don't require any blood transfusion as a part of the process. Some of the patients might be aware of this procedure called plasma exchange, which is sometimes used in patients with myasthenia, especially if they're not doing well there in the hospital. So in essence, it's very similar to that process, perhaps even simpler, because it's a one-time session where we extract patients' own cells, but they don't actually require any blood transfusions or additional treatments. And that's a very simple process done as an outpatient at the infusion center, but you don't require any further infusion therapies of any kind. And most of the time, patients come for the apheresis and they go home the same day. They don't require any further treatments on that day. And then there was an earlier question about how long it takes before the T cells are produced, the CAR T cells. This depends upon individual companies and their life cycle, usually, a few weeks. It won't be available the next day, for example. So it's not that kind of treatment where you can come back the next day to get a treatment. But I know, including Kyverna, is trying their best to reduce that lifetime to make that really shorter so that as soon as the cells are taken from you, they're shipped off and then they're ready to be given as quickly as possible. But in the clinical trial, it'll at least be a few weeks. Your treating physician or research physician will continue to be actively engaged in your care during that period where the cells are taken up before you're ready to get the KYV-101 or standard of care, making sure that you are doing well and your myasthenia is stable. And so there is a lot of active involvement from you, patient with myasthenia, and then your research team during this acute part of it. We did not go into the details of it. There are many, many team members. At least, for example, at Stanford, there are probably about 50 team members that take care of different aspects of this. So there's a schedule given to the patients. We try to stick to the schedule because a lot of different teams have to come together on different days to make it happen.
Yeah, and I would just add in the phase 3 part of the trial, as you said, Professor Mukherjee, from apheresis, patients will go back on standard of care treatment for 2 months while we are manufacturing the cells before they get into randomization. So there's a 8 weeks period in this trial by design before patients will be being randomized between KYV-101 or standard of care. Another really great question is on previous treatment that are B-cell depletion therapies, and if that would change the response, or if B-cell numbers are low to 0 from prior treatment, will that change the response? And I know we both discussed this even in the data from the phase 2, so I'll let you comment on this.
Yeah, so in the phase 2 study that was shared about the 6 patients, some of them previously had rituximab and did not have a great response, but then had a great response to KYV-101. So that's very promising. It goes back to earlier question about how much more beneficial CAR-T might be in targeting B cells compared to something like rituximab or other monoclonal therapies. The phase 3 protocol has a strict criteria for about 6 months from the last time you had a B cell therapy. And then I think regarding what do the B cells numbers look like and other criteria look like, it might be very individualized to the patient regarding their disease burden and what their numbers look like to decide on an individual basis. But having had a rituximab therapy, for example, in the past, does not automatically exclude you.
Great. So another question is about if this can possibly be used in other diseases, other autoimmune diseases like scleroderma, for example, or others.
Yeah, so again, under the research protocol, as Naji mentioned earlier, these therapies are not currently FDA approved for any other autoimmune diseases, but there are many other autoimmune diseases where it's being studied, including lupus, including scleroderma, Stanford is one of the sites for some of these trials done with our rheumatology colleagues. And so certainly could be done in the research protocols. I can see the logic behind the question. If you have one drug that can take care of two rare autoimmune diseases, it's great. We could probably be the best person to get it. It does require, we need to look at an individual patient before promising yes or no, because it does depend upon what else is going on with their overall disease burden with different autoimmune diseases. But just to specifically answer the question, it is being studied in multiple autoimmune diseases in the rheumatology side of things, not just the neurology autoimmune diseases.
Yes, and as I shared, we're focused as a company in neuroimmunology. So we have a pivotal trial, for example, in stiff person syndrome, but we also did other indications like lupus, multiple sclerosis, rheumatoid arthritis, as you shared, Professor Mupedi, and CAR-Ts are now, there's more than 40 clinical trials in different indications across different companies researching the field, as we also presented. There is a question about the multiple antibody and patients with multiple autoimmune disease, and this is really a great questions that we receive. And there's an additional question to it with insulin requiring immune diabetes. Do you want to?
Yeah, so I think just to make sure that, again, the larger audience is on the same page, for the phase 3 protocol, it has fairly strict criteria because we do want to capture patients who have myasthenia as their primary disease, disabled because of myasthenia or have a lot of myasthenia-related symptoms, so that we can assess how they do with the treatment. But these therapies are being developed, and I'm talking about the larger CAR-T treatments across the board, are being developed for multiple autoimmune diseases. It's very difficult to, and sometimes challenging to recruit patients with different autoimmune diseases into a study of this kind, only because it becomes difficult to measure how much of their disease burden is related to different aspects of different diseases. But I'm optimistic going forward in future, patients who have multiple antibody-mediated autoimmune diseases might be actually the ideal patient for these kinds of therapies early in the disease process, irrespective of clinical trial protocol, so that they can actually have a deep impact on their disease burden, because you have one therapy that can potentially impact all the diseases.
So I'll go with, I think we have maybe one more question. We can go, and we'll make sure, please don't hesitate to reach out, and we will answer more questions. But there is one that is also very important. If the therapy destroys all B cells, isn't that dangerous? And how would the modified T cells know what to destroy? So maybe Professor Mupedi, if you want to start with this, and then I can add on.
Sure, absolutely,
what we've seen in research, yeah.
So there is a life cycle to the B cells, as I mentioned. CD19 is expressed in a broad spectrum of the B cells, but not every B cell. There are B cells that do not express CD19. For example, let's say plasma cells. Some plasma cells don't have CD19 on them. And so you still have some B cells that are there to fight against infections and so on and so forth. That's number one. And the CAR T cells, the CAR stands for that extra receptor, the little red wrench that you saw in the slides earlier. That's what detects the B cell. So it only knows to, and it is programmed to only attack the B cells, not additional cells. And the CAR T cells attack the B cells, and then that's what causes the sort of reduction in the B cell counts. From the data that's been published to date, many of the patients over a period of time regenerate new B cells. But the new B cells, magically, don't have the same properties as the old B cells, especially the ones that are producing the antibodies. We know from published data that patients who have antibody-mediated disease, the antibody levels go down at the beginning, the B cell levels go down. But after a while, the B cell level starts coming back up, but the antibody level doesn't necessarily come back up. And so you are able to regenerate some of these cells. But as I mentioned at the beginning, A, this is a clinical trial. B, we monitor patients longitudinally. Sometimes patients are given as a part of the protocol additional antibiotics to prevent infections during the acute part of the treatment trial. So we do take the idea of suppressing B cells very seriously, and we monitor patients closely. But from the published literature to date, it's been thankfully quite safe.
Yeah, well, thank you for that. And this is what's been published in the medical community, what we're talking about as immune reset, right? Like this B cell depletion and then repopulation that is allowing to have potentially those effects. And this is exactly why we need to run those clinical trials to make sure that we are seeing these effects clinically for patients. We are on time. I would ask you, Professor Mupedi, if you have any final words before we wrap up.
Whenever I participate in any of the MGFA event, I'm surprised for a rare disease, the degree of patient engagement. I give a lot of credit to MGFA for how well they have done with organizing these events. I hope you enjoyed this session. And certainly reach out to the website, reach out to the email so that if you feel like you would be a good candidate, we can connect you to the right person. But beyond this, I think this is an exciting time for the MG field as it is, because finally we are talking actively about controlling diseases, symptoms significantly for a long period of time, simplifying their treatment regimen so that our patients can go back to do what they want to do and not be burdened by either the symptoms or the ongoing treatment. And CAR-T really has an ability with one-time infusion, both control symptoms and minimize or take away need for ongoing treatment. Thank you.
Thanks again, Professor Mupedi. Thanks for the MGFA team here for having us. Don't hesitate if we didn't answer your questions here. We're sorry due to the restriction of times, but you can certainly email clinicaltrials.info@kyverna.tx.com, and we will make sure we can provide the medical information that you need. Before we wrap up, I just want to make sure that I take a moment to thank all the patients and clinical trial participants and their families who make progress in science possible. Behind every results that we shared today and that we share in the medical community and in our industry is people who've given their time, their trust, and we are deeply grateful for that and for everything you do to move medicine forward.
Thank you both so much. Thank you everybody for joining us. We wish you well the rest of your day, and we hope to see you again soon. Take care.